Good afternoon, friends. It's a great honor to be before you today, this afternoon, to give this oration which has been bestowed on me by the Andhra Pradesh Orthopaedic Association for their OSAPCon. My talk is about the proximal femoral fractures, which are the commonest fractures in the elderly. And before 1940, all these fractures were treated non-operatively with poor results. Currently, they are treated surgically, and yet not all of them have got good results. You can see from a page copied from a textbook that 50% never recover fully, 20% die within a year, 30% have got permanent disability, and 40% are unable to walk. This oration will be a little different because this discusses an entirely different method of management of some of these fractures based on sound orthopedic principles of Charnley, Sarmiento, and Wolf. We can see a patient with an intertrochanteric fracture on her right side. She is a female of 78 years of age who has had a coronary artery bypass graft, had a trochanteric fracture, had a past stroke, medically unfit for any surgical procedure, in severe pain. The patient is being explained that she is going to be treated by a new method. Her groin is cleaned and draped. A Chennai cocktail is drawn. The attending physician, who is my brother-in-law, is palpating the femoral neurovascular bundle, and he is going one finger breadth lateral to the femoral nerve into the inguinal crease, and he is injecting 4 to 5 ml of the special concoction which we have called Chennai cocktail. Within 10 minutes of the injection, the patient is herself spontaneously moving her leg, and then once she is given a walker, she is happily walking on a stable trochanteric fracture within 20 minutes of giving her an injection. The husband, who is standing outside the door, is extremely surprised because 3 orthopedic surgeons have told her that she needs a surgery, and there is close to 20% mortality risk with any surgical procedure in her. And if she doesn't get operated, she will die of chest infection and bed sores. Thereafter, the patient no longer needed a physiotherapist or an occupational therapist. The husband was looking after her, and she first started walking to the toilet and thereafter started walking outside the room on her own without any assistance, walking on the fracture. And believe me, without a DHS, without a PFN, without a condylar plate, without metals, without any surgical risks, this patient had a solid union of a trochanteric fracture on the 92nd day. So, without a traction, without a hip spica, without immobility or its risks, the patient is just encouraged to walk on the fracture, which the patient shall happily be doing had it not been for the pain of the fracture fragment grating with one another. And DSCB, or Distal Sodium Channel Blocks, have revolutionized and changed the concept of fracture management. Another case, you can see the X-rays on day 1, day 30 and day 80. No form of internal fixation was done. Another case, day 1, day 30 and day 80. Imagine a fracture uniting in 80 days without any surgical complications and without any surgical risks. Another patient, day 1 and day 91. Just 3 months it has taken for the fracture to unite. This revolutionary new way is useful in stable intertrochanteric fractures and valgus impacted neck of femur fractures. No traction, immobilization, spica or plaster is needed. No DHS, PFN or condyle plate is needed. And this procedure is based on essential orthopedic principles which have proved the test over time. Normally, a trochanteric fracture has severe pain, patient is horizontally crucified, hip spica and traction are not tolerated by the elderly patient. Elderly patients have an implant cut through and they have a high surgical mortality and morbidity if you operate on them. What happens is the serious disbalance between the abductor lever arm, the abductor muscles, the adductor lever arm, the adductor muscles, and invariably pulls the leg into a biomechanically unstable position, causing long term complications if you don't fix its stability. However, if you are able to make a patient walk with a stable IT fracture, results should be dramatic. In the year 2021, many things have come out together and have helped us to present this paper to you. During the year 2020, operations in the operating room because of Wuhan virus became dangerous. Above is a paper that I published in an international journal. And as I was not operating, my close friend Divakar and I were discussing endless hours on Zoom calls, working on the biomechanics of the hips and pros and cons of making a patient walk without a metal. We identified that adductor spasm was the principal cause of varus malunion of non-operatively treated intertrochanteric fractures. And our revolutionary new way of distal sodium channel block relieved the adductor spasm, allowed a valgus hip, and became a game changer in orthopedics and pain management that allowed the fracture to heal in extremely satisfactory position, compliant, and making both the patient happy and the surgeon extremely happy. DSCB is a phrase coined by the authors for a new era of pain management which has been evolved after a lot of experiment and trouble. Though the injection, its dilution, and composition remain same for all portals, the volume and depth are different. The upper limb portals are called alpha portals, lower limbs are called the beta portals, trunk portals are called the tau portals, and head and neck portals are called the caput portals. And these portals have a specific location, specific depth, specific volume, specific indication, purpose, and a specific interval of action. The duration of relief varies from minimum of 2 days to a maximum minimum month, many months. And in case the duration is too short, one has to analyze where we went wrong. Though these portals were initially described for neurogenic and spine problems, in trauma, they have become such big game changers that those uninitiated to the system can barely comprehend its capabilities and the miracles it is capable of producing. From ancient times, it has been the physician's responsibility to relieve pain, and pain is one of the most important symptoms for which the patient comes to us, which is a complex process starting from the peripheral skin area, going right to the vein, traveling through various neural channels. The beta 6 portal, which is used for this management, is a spot adjacent to the femoral nerve in the inguinal region, subfascial, with a 3 to 4 ml volume. This is used for originally pain management in fracture femurs, emergency pain management, trochanteric, subcapital, and acetabular fractures, dislocated hip for reduction, pelvic fractures, greater and lesser velocity fractures. However, with experience, we learned that beta 6 portal can also be used as a sole pain management portal modality in the revolutionary block and walk method. This talk will now teach you how to make beta 6 portal DSCB as a definitive management for stable intertrochanteric fractures using what we shall call the block and walk technology. The picture shows you the femoral neurovascular bundle in a graphic format. Keep a finger on the femoral nerve and one finger breadth lateral to the femoral nerve. Inject the cocktail. The time for effect will be in 10 minutes. The duration of relief is short, 6 to 7 days. In fractures treated ergonomically, we may need to repeat the injections between 3 to 7 days. If we inject the Chennai cocktail, it gives 6 to 8 days relief, whereas plain lidocaine gives only 3 to 5 days pain relief. What is Chennai cocktail? It is 1 ml of lidocaine with xylocaine with 30 micrograms of clonidine. It is 0.2 ml and diluted with 3 ml of water for injection. If clonidine is not available, use dexmedetomidine 5 micrograms. If neither are available, just 0.5% lidocaine is enough, but the block needs to be repeated to ensure that the patient remains pain-free and walks. You can see from the X-ray above, the patient has a displaced trochanteric fracture, however stable. He's explaining that he has severe pain and is not able to move the limb even a little. This patient had come to my Chennai clinic while I was in Palakkad, and on a video call, my nurse is injecting a beta 6 portal with 0.5% lidocaine, 30 microgram clonidine. No steroid has been added to this. The injection is practically painless. You can see the patient's expression. Subsequently, the patient's son and daughter-in-law are making him stand up, and he is just touching his foot to the ground, ensuring that he finds his bearings. They are attempting to lift him up when my nurse instructs them not to assist him too much and allow him to weight bear on his own so that we know whether the strategy is going to work or not. At this stage, with caution, we allow the patient to take a few steps and walk on the fracture. I have already shown you one video before, and this is a very, very recent video on the BAST patients. And here you can see in the hospital in Chennai, the patient is walking first a little cautiously and then a little more confidently, and subsequently a little more energetically. The patient remained in the hospital only for a period of 2 hours. That is him on the next day at home. And it was his daughter who sent me the image. He's independently mobile to the toilet. He walks to the dining table and he has absolutely no pain. It is 5-6 days since the first injection. On 7th day, hopefully my nurse will go to his house and give him an injection. He's explaining that previously he was feeling the fracture. Now he's happy, and that is the X-ray. On 21st day, I expect this fracture to heal in lesser than 90 days with a shortening of less than 1 centimeter. Such miraculous results is only because of DSCV. And what is the mechanism that allows this miracle to happen? Relief of adductor spasm prevents varus ball union. If you look at the hip adductors, you find that they are all concentrated from both the spine and pelvis to the lesser trochanter. And when there is a disassociation between the lesser and greater trochanters, it is logical for the proximal fragment to go into abduction and distal fragment to come into adduction, leading to a physiologically unfavorable varus deformity. On the contrary, imagine the blue line in the arrow is no longer pulling the lesser trochanter and is fully relaxed. What will happen? When a patient is advised to walk with abduction, he will compress the fracture in valgus. I'm just running through a few examples for you. This is a case, a female. I think she was about 80 years old. Day 1, day 30, and day 80. Next case, another female, about 78 years old. Day 1, day 30, and day 80. I have seen patients with DHS and PFN still struggling with a walker on the 80th day. Here we have on day 1 and day 91, though this was a little varus manunion with 1 centimeter shortening, this patient also refused any shoe raise. Another one, at 73 days, the patient had got rid of the walker and was walking with either little or no support. Imagine. And this one was subtrochanteric fracture, again treated by same modality of DSCB walk and block. And you can see the results on day 1 and day 91. This really shocked me and opened my eyes. You can see another patient on day 11 and day 100. So these fractures have been uniting in an average of 2 to 3.5 months. Whereas operated fractures have taken 6 months and a year, multiple surgeries, morbidity, mortalities, and death. Day 13, day 96. See how beautifully the fracture is uniting. I have been very careful in selecting proper cases. This is one of my early case, which was not an ideal indication. Still the patient is so happy. He just has a shortening of about 2 centimeters. And this, surprisingly, was a reverse oblique fracture. And even this reverse oblique fracture united with zero shortening and normal function. So what are the ideal indications for block and walk method of treatment? Stable Inter Trochanteric fractures, valgus impacted subcapital neck of femur, femoral fractures. What else? This is an ideal case of a valgus impacted neck of femur. And you can see the fracture is here, but it is nice and well impacted. All I did was gave her a beta 6 block and nasal calcitonin puff for osteoporosis, walked her, and you can see the ergonomic results in 45 days. As we continue to discuss our cases, Dr. Divakar too started trying it in his clinic, and this is his 15th day result of a granny who was 93 years old. And you can see this valgus impacted fracture neck of femur, and this patient is walking without any support on the 33rd day of her fall. Again, this is a very recent picture taken a few days ago. Likewise, we have had numerous examples of cases we have done, and I think to date we have crossed 31 cases of intracapsular and extracapsular fractures, 7 intracapsular fractures, and 24 extracapsular fractures. And towards the end of the talk, I shall be showing you my results. This is again in Dr. Divakar's case, and you can see the beautiful union in less than 45 days. Valgus impacted fracture, no screws, a very elderly lady. And here you can see how comfortably she is getting up and she is walking. Of course, we ensure that we give high protein diet, we give vitamin D on Sundays, we manage osteoporosis. We do not advise teriparatide, but nasal calcitonin, of course, we advise. Patient says she has absolutely no pain and she is very comfortable and happy with her fracture situation. It is very important to understand that we cannot learn with closed eyes. You can see a child of 14 years of age who had a vertical fracture, which should have ideally been treated by a valgus osteotomy. However, due to corona times, surgery was not contemplated. He was just blocked and walked. And you can see that in 45 days, the fracture united. This essentially teaches us a lesson that function is the key. The patients were between 50 to 70. Older patients were higher than younger patients. Honorable VAS score was 9. They were very, very painful. And after DSCB, it came down to 2, meaning they were pain-free and comfortable. The healing time mostly was within 70 days. Only 14% fractures took up to 120 days. Whereas this, and likewise shortening, we hope or expected the shortening will be very large. Only 14% patients had shortening of 1.5 to 3 centimeters, whereas half the patients had shortening less than 0.5 centimeters. The Harris-Hip score was 85 to 90, 90 to 95, and above 95. Only one patient who was moribund pre-treatment had a bad Harris score. And on a scale of 1 to 5, the patient Hip score was either 4 or 5. So that was a magic. These DSCV blocks produce such outstanding results that they even surprised me. So the take-home message for us today is stable inter trochanteric and valgus impacted subcapital neck of fractures are not fractures of necessity. Not all proximal fractures of femur need surgery. Bad results of non-operative management have been because of traction, hip spica, immobilization, bed sore, urinary tract infection, and chest infection. Bad results of operative management in the past have been because of bad porotic bones or bad techniques. Bones are soft and cheesy. Implants are rigid and stiff. Orthopedic surgeons have been so blinded with metal and radiographs that in the past 50 years, nobody has made any efforts to improve the implant or surgical technique. Non-operative methods have always been given a stepmotherly treatment. I am not advocating that this should be used in all proximal fractures. They have specific place in the precisely correct indications. They are not indicated if the patient is anesthetically fit and willing for surgery, not indicated in displaced subcapital fractures, not indicated when the patient is unwilling to accept shortening, and reverse oblique and badly comminuted fractures are not proper indications. This is a revolutionary new method in selected fractures. Try the procedure exactly as described with an open mind, and you will be surprised with the results. Unless you unlearn, you can seldom learn. And with this, I conclude my oration with a special thanks to Professor Atmaram and his team for the wonderful event that OSAPCon 2021 is doing and has done by giving me an opportunity to present this oration. Thank you.